It's Patrick Hutzel from IntensiveCareHotline.com. Welcome to another ebook in IntensiveCareHotline.com's ebook series. And once again, congratulations for taking action, getting informed and taking control. And thanks again for purchasing the 10 answers to the 10 most frequently asked questions when your loved one isn't waking up after an induced coma. So just by you getting informed and just by you doing that, you stand out from the rest of the families in intensive care, and it'll give you an edge when dealing with the challenges, difficulties and complexities in intensive care. Our ebook, video and audio series will help you finding your voice in the jungle of complexities surrounding intensive care. This ebook and videos will help you to master the challenges when it comes to your critically ill loved one not waking up after an induced coma. When I first started out with my website and my online counselling and consulting IntensiveCareHotline.com, I actually didn't realize how many frustrations, anxieties and simply unknowns there are for families in intensive care when it comes to their loved one not waking up after an induced coma. I initially and also wrongly assumed that most doctors and nurses in intensive care would just simply explain to families of critically ill patients in intensive care how and when your loved one will wake up after an induced coma. This is certainly what I do when I'm caring for a critically ill patient and their family in intensive care, and it is what all health professionals in intensive care should be doing. The reality is that intensive care health professionals are busy people. However, part of their jobs, as well as part of their moral and ethical obligations, is to explain to you and your family what to expect when your loved one is coming out of an induced coma. My practice of nearly 20 years experience in intensive care nursing has shown me that waking up in intensive care is not linear, and nor is it straightforward like in a textbook or in a manual. However, this ebook and video, as well as the audio recording, will come as close to a manual or even a cheat sheet as it can possibly get when it comes to the challenges of not waking up in intensive care. There is no straight line when it comes to waking up after an induced coma, and there simply is no such thing as one size fits all. Your loved one who's critically ill in intensive care is an individual, and therefore they will literally have an individual awakening. Therefore, your critically ill loved one will wake up in their own time, no matter how much you or the intensive care team wants to speed up the process. What I have also discovered over the many years whilst working in intensive care is that most families who have a loved one critically ill in intensive care have specific questions when the loved one is in an induced coma and is not waking up. Those specific questions I have collected over the many years, and here's the result of those questions and answers in this ebook, videos and audio recordings. I know it's extremely challenging and frightening for anyone to have a loved one critically ill in intensive care, and as I have learned in nearly 20 years intensive care nursing in 3 different countries, where I literally worked with thousands of critically ill patients and their families, is that an induced coma is like a venture into the unknown for families in intensive care. Just being in an induced coma is a massive challenge for a critically ill patient, and it's also a massive challenge for families in intensive care. It's even more challenging, frightening and difficult for families of critically ill patients in intensive care if their critically ill loved one isn't waking up after an induced coma. Therefore, families in intensive care have millions of questions running through their mind, desperately seeking for answers during this challenging and often once-in-a-lifetime situation. And without further ado, I really want to give you now the 10 answers to the 10 most frequently asked questions when your loved one isn't waking up after an induced coma. So, let's start with number 1. Why is my critically ill loved one not waking up after an induced coma? I have looked after countless critically ill patients in intensive care, and I have lost count. The number is probably in the thousands or even in the tens of thousands. I simply don't know. The vast majority of those critically ill patients that I have looked after would have been in an induced coma at some point or another during their stay in intensive care. What's interesting to know is that no matter the length of an induced coma, coming out of the induced coma seems to be very challenging for some critically ill patients compared to others. And this is why you are here. You want to know why your critically ill loved one hasn't come out of the induced coma yet. Let me explain. Most patients in intensive care that are induced into a coma for their critical illness also require mechanical ventilation and a breathing tube. The following admission scenarios in intensive care often lead to mechanical ventilation, a breathing tube, and an induced coma. Pneumonia, open heart surgery, stroke, sepsis, which is basically a globalized severe infection, often resulting in multi-organ failure, pneumonia, multi-trauma, severe head or brain injuries, heart attack, cardiac arrest, abdominal aneurysm repair, ARDS or lung failure, drug overdose, Guillain-Barré syndrome, liver failure, liver transplant, ECMO, heart transplant, lung transplant, seizures, and the list goes on. However, I have listed the most common types of admissions into intensive care that require mechanical ventilation and then an induced coma. You may ask, and you may want to know, what's first, the induced coma or mechanical ventilation? It's really a chicken versus egg question, and it's a great question to ask, and to tell you the truth, it's often a combination of both. From an intensive care perspective, if a critically ill patient needs mechanical ventilation, they are induced into a coma the minute they are intubated. And intubation is the insertion of a breathing tube into the throat, and they are also then ventilated. Mechanical ventilation and the insertion of a breathing tube tend to be so uncomfortable and painful that this intervention couldn't be tolerated without sedatives and strong painkillers. Hence, the coma is induced with strong painkillers and opiates such as morphine or fentanyl, and also sedatives, which are, the names of the sedatives are midazolam or Versed or propofol, and the other name for propofol is Diprovan, and that is required in order to start mechanical ventilation. All medications are given intravenously or in a drip to get rapid results. In most critical illnesses, breathing is compromised, and therefore mechanical ventilation is necessary to take over the breathing function. Therefore, the mechanical ventilation and the breathing tube have a life-saving function. As I explained above, mechanical ventilation and the breathing tube couldn't be tolerated without the induction of a coma. Now, I really have to throw something in here that might answer some of your burning questions already. Whenever a critically ill patient is induced into a coma and is not on the brink of dying and is not having a severe head or brain injury, they most likely will wake up once the sedation has been removed. This is really important for you to know and understand. With the exception of a critically ill patient dying in intensive care, and with the exception of severe head and brain injuries, your critically ill loved one will wake up after coming out of the induced coma. I am not, however, putting a time frame out here. However, I can assure you that your critically ill loved one will wake up sooner or later. The reason I want to make this perfectly clear is because I get so many families of critically ill patients in intensive care impatiently awaiting waking up of their loved one after an induced coma. This may also explain to you why you may find that most doctors and nurses in intensive care are kind of casual about your loved one not waking up after an induced coma. I have found that most families of critically ill patients in intensive care are panic-stricken when their loved one isn't waking up after coming out of an induced coma. As I have said before, relax. So the only exception really is when your critically ill loved one is really dying or is having a severe head or brain injury. Your critically ill loved one will wake up after they have come out of the induced coma. Doctors and nurses in intensive care know that, and that's why they're so relaxed and casual about it. They have seen it over and over again. Critical illness in intensive care, including waking up after an induced coma, is not a Formula 1 race. It's more like a snail or a turtle race. It's more like a crawl to the finish line instead of a fast-paced race. Now that I've given away one of the most important answers to your burning questions, does that mean you should stop watching this video? No, definitely not, because what's about to come is just as important as what I've shared with you thus far. One of the reasons why your critically ill loved one isn't waking up quickly is because, after all, your loved one is critically ill and needs time to heal and rest. And no matter how much you, your family, or even the intensive care team wants your critically ill loved one to wake up now, they will do so in their own time, no matter how much you want to speed up the process. Also, your critically ill loved one just had massive amounts of sedatives and painkillers, also opiates, to be able to tolerate the mechanical ventilation and the breathing tube. Sometimes, your critically ill loved one may have also received muscle relaxation medications in order to help facilitate mechanical ventilation and the induced coma, most likely further prolonging waking up after the induced coma, because the need for more sedatives is even higher when muscle relaxation medications have been used. All of the muscle relaxation medications, the sedatives, midazolam, Versed, or propofol or diprivan, and the opiates and strong painkillers such as morphine or fentanyl have accumulated in the body system of your critically ill loved one. And even though they may have been reduced or even taken away completely, they are still floating around in the body system, further delaying waking up. Also, some critically ill patients may have also gone into kidney failure and or liver failure during the course of their critical illness, further delaying the metabolism of the sedative and opiate drugs and therefore further delaying waking up. This concludes the answer to question number 1, and now let's move on to the most frequently asked question number 2. How long will it take for my critically ill loved one to wake up after an induced coma? Waking up for critically ill patients in intensive care after an induced coma is never linear, straightforward, or textbook-like. Again, there is no such thing as one size fits all when it comes to waking up after an induced coma. One thing I need to explain here is that the longer your critically ill loved one is or has been in an induced coma, the higher the risk and the likelihood that waking up is even more delayed. However, sometimes even being in an induced coma for up to 72 hours can cause a delay in waking up. So you may want to know, what's the difference? The difference that often makes the difference is not so much the length of time spent in an induced coma. The difference is often in the nature of the critical illness. Another factor is age. With increasing age, there is a higher chance that waking up after an induced coma is delayed. From experience, anybody above the age of 65 is at higher risk of waking up slower after an induced coma compared to younger patients. Age doesn't necessarily have to be a factor, but it can be a factor. However, anybody induced into a coma is at risk of waking up slowly after an induced coma. For example, if your critically ill loved one has been admitted to intensive care with a cardiac arrest, has been induced into a coma for up to 72 hours because they have started cooling therapy to protect the brain and other vital organ functions, you would think that waking up should be relatively quick and straightforward. This particular patient didn't wake up for another 72 hours after taken out of the induced coma. However, I have also seen critically ill patients that have come out of an induced coma quickly and woke up almost immediately after 72 hours in an induced coma and mechanical ventilation after cardiac arrest, including cooling therapy. From experience, up to 72 hours in an induced coma is not a very long time from an intensive care perspective. From a patient and family perspective, 72 hours can feel like an eternity, and the waiting for families can become unbearable. In reality, waking up after a 72-hour induced coma can just take as long as waking up after 10 days in an induced coma. Again, this can be due to age factors, as generally speaking, increased age is often going hand in hand with a delay in waking up after an induced coma, but it doesn't have to. Younger, critically ill patients in an induced coma may just face similar challenges in waking up after an induced coma in comparison to older, critically ill patients. As a rule of thumb, critically ill patients above the age of 65 tend to take longer to wake up after an induced coma, but they don't necessarily have to, just as much as younger, critically ill patients don't necessarily have to wake up quicker in comparison to older patients. It really all depends. So, let's look at this in more detail. Let's just quickly stick with a critically ill patient who had a severe motor vehicle accident, or an MVA. They've come to intensive care with multiple fractures, including broken ribs, but no head or brain injuries. They had to be intubated, which again is the insertion of a breathing tube, and they had to be placed on mechanical ventilation in an induced coma because of their inability to breathe with rib fractures. After 72 hours, they were taken off sedation. They woke up within 12 hours of removing the sedation, and therefore they were able to come off the ventilator, which is also called extubation or removal of the breathing tube, and they came off reasonably quickly without much delay. But it could have been the other way round as well. The patient could have been taken off sedation and not woken up for another 3 days or even 5 days. Two examples of inducing a coma for different reasons. One a patient after cardiac arrest, and the other patient induced in a coma after a motor vehicle accident. One was waking up quickly and the other one wasn't waking up quickly at all. To illustrate those two examples even more, I could have picked other scenarios as well. For example, I could have picked a critically ill patient with a pneumonia, with open heart surgery, and the list goes on. Again, there simply is no such thing as one size fits all when it comes to waking up after an induced coma. What also needs explaining in more detail is that differences in sedatives and opiate drugs, again, opiate drugs are strong painkillers, can make a difference in how quick your critically ill loved one may or may not wake up after an induced coma. Let me explain. Whenever a critically ill patient is induced into a coma and commenced on mechanical ventilation, there are a few drugs that are commonly used. There is a significant difference in how those drugs interact with your critically ill loved one, and there is a significant difference in how this might play out when it comes to waking up when coming out of an induced coma. The main difference that's important for you to know and understand is the difference between long-acting and short-acting sedative drugs. When inducing a critically ill patient into an induced coma, the two sedative drugs of choice tend to be midazolam, also called Versed, and propofol, which is Diprivan. Midazolam or Versed is a long-acting sedative and propofol is a short-acting sedative. Both have very different half-lives, and therefore midazolam or Versed takes longer to get out of the body system through metabolization, and propofol, also called Diprivan, only takes a short time to be metabolized. In theory as well as in practice, propofol or Diprivan is the drug of choice for a critically ill patient in anticipation of an induced coma that only lasts for a few days. Now, I really need to put things in perspective here. If your loved one is critically ill in intensive care and only requires an induced coma and mechanical ventilation for 48 to 72 hours, it's not a very long time in intensive care terms. However, it most likely feels like an eternity for you and your family, let alone if the coma goes on for many days and sometimes even many weeks. Therefore, it makes a lot of sense to start an induced coma with propofol or Diprivan instead of midazolam or Versed. Therefore, the drugs being used whilst your critically ill loved one is in an induced coma will make a difference in how long it'll take your critically ill loved one to wake up after the induced coma. There are of course other factors as well, such as the critical illness your loved one is dealing with, as well as if your critically ill loved one is dealing with other issues such as withdrawing from alcohol or drug abuse. However, as a rule of thumb, for an induced coma that's likely to last for a short period of time, propofol or Diprivan should be used, and for an induced coma that is expected to last longer, midazolam or Versed should be used. It therefore also makes sense to start an induced coma off with propofol or Diprivan and then go on to use midazolam or Versed if the induced coma continues and if your critically ill loved one is likely to stay ventilated and sedated for longer than anticipated. In some instances, propofol or Diprivan and midazolam or Versed are used in combination, mainly if either propofol or Diprivan or midazolam or Versed are not potent enough to keep your critically ill loved one sedated enough and therefore safe. Safety whilst being in an induced coma is a big issue, and whilst not waking up after an induced coma can be a big issue as well, being too awake during an induced coma can be a big issue too, because mechanical ventilation needs to be safe, and this can only be achieved if the sedative drugs have the desired effect to keep a critically ill patient asleep and in the induced coma. On top of the sedative drugs, propofol or Diprivan and midazolam or Versed, there are the opiate drugs or the painkiller drugs being used, such as morphine or fentanyl. In some instances, remifentanil or oxycodone may be used as well. Here are the things that you need to know about the opiate drugs morphine and fentanyl. Both are very effective drugs when it comes to the management of pain. Most critically ill patients in intensive care that are induced into a coma need those strong painkillers in order to not only tolerate mechanical ventilation and the breathing tube in their throat, they also need those painkillers to deal with post-surgery pain or pain from other injuries they may have sustained. Just like propofol or diprivan and midazolam or Versed, morphine and fentanyl come with undesired side effects. For propofol, the main undesired side effect is hypotension. Hypotension also stands for low blood pressure. For midazolam or Versed, the most undesired side effects are longer half-life, and therefore the longer periods of time midazolam or Versed has been given, the longer waking up can take when coming out of the induced coma. Midazolam or Versed is also classified as a benzodiazepine, and benzodiazepines, also called benzos, can be addictive after long-term use. Therefore, the longer midazolam or Versed is being used, the higher the chances that your critically ill loved one is going through withdrawal when waking up after an induced coma. The same applies for morphine, fentanyl, remifentanil or oxycodone. Those opiate drugs are highly effective to manage pain and are also addictive when it comes to long-term use of such. Therefore, the long-term use and combination of opiate drugs such as morphine, fentanyl, remifentanil or oxycodone and midazolam or Versed can cause addiction and also withdrawal symptoms when it comes to waking up after an induced coma. It also means that the combination of propofol or diprivan and morphine or fentanyl appears to be the less harmful choice when it comes to an induced coma, and the combination of propofol or diprivan and morphine or fentanyl is often given preference above midazolam, Versed and morphine or fentanyl. In theory, waking up should be easier and quicker after propofol and diprivan use combined with morphine or fentanyl. Again, propofol or diprivan is a short-acting sedative with a shorter half-life compared to midazolam or Versed. Therefore, most patients can wake up very quickly after propofol or diprivan has been seized. Waking up quickly after seizing propofol or diprivan is more likely compared to midazolam or Versed usage after an induced coma. However, if there is a delay in waking up after an induced coma when propofol has been used, the delay can often be due to the usage of morphine or fentanyl. Again, morphine and fentanyl are strong painkillers, and therefore the accumulation of those drugs can cause a delay as well. As I have briefly touched on, propofol or diprivan should be used for a short-term induced coma, which is also classified as up to 72 hours, and midazolam or Versed should be used for an induced coma that lasts more than 72 hours. One of the most common and also undesirable side effects that propofol or diprivan has is hypotension, which is a low blood pressure. Therefore, the combination of a critical illness, hemodynamic instability, which comes with most critical illnesses, and the undesired low blood pressure make it all the more likely that inotropes need to be used to stabilize your critically ill loved one. Inotropes are intravenous drugs to increase the contractility of the heart and also constrict the blood vessels to achieve a higher blood pressure in critically ill patients. Inotropes are drugs that can only be given in intensive care units or in the emergency room, as they need close monitoring by experienced and critical care trained staff. With this example, you can see the advantages and also disadvantages that propofol or diprivan has. It therefore makes sense to use midazolam or worse whenever an induced coma is expected to be lasting more than 72 hours, and also if there is significant hemodynamic instability. The combination of midazolam or worse and either morphine or fentanyl tends to be a powerful and also effective combination for an effective and deep induced coma. Therefore, an induced coma with midazolam, verse and morphine or fentanyl that lasts for many days or sometimes even weeks can be difficult to get out of. Midazolam or verse as well as morphine or fentanyl can be highly addictive in nature and also float around in the body system much longer than propofol or diprovan because the half-life is so much longer. Therefore, waking up is almost expected to be delayed and slow after a prolonged induced coma with midazolam or verse and morphine or fentanyl. Therefore, if your critically ill loved one finally is waking up, it can be a slow process, and during this process, your critically ill loved one may show signs of withdrawal from the midazolam and fentanyl or morphine. Normally, when getting out of the induced coma, especially when midazolam, verse and fentanyl or morphine are being used, it should be a gradual weaning process by weaning the doses down over hours or even days. Especially since midazolam or verse and fentanyl or morphine are addictive in nature, a gradual weaning makes sense rather than just taking it away. A potential withdrawal only needs to be managed medically if your critically ill loved one shows symptoms of withdrawal. Furthermore, there is a very high chance that once your critically ill loved one is finally waking up, that they're going through a period of confusion, agitation, delirium and aggression. You may see a drastic personality change in your critically ill loved one for a period of time. It's often part of waking up after an induced coma, but it doesn't necessarily have to be part of the process. The longer your critically ill loved one has been in an induced coma, the higher the likelihood that they will be confused, agitated and delirious. This confusion, agitation and delirium can often last as long as to the point of discharge from intensive care. A lot of research has shown that most critically ill patients in intensive care who have been in an induced coma for any period of time don't remember much about their stay in intensive care, even though they would have been awake at some stage during their ICU stay. Please also keep in mind that no matter how difficult this seems for you to watch your critically ill loved one to not wake up after an induced coma, or watch them being confused, agitated and delirious, it unfortunately comes with the territory and it often can't be avoided. Critical care medicine and nursing has come a long way in the last 2 or 3 decades. However, managing the delays in waking up after an induced coma, as well as the management of confusion, agitation and delirium, remain a big challenge, and I know from experience that it's not very nice to watch. You've got to be patient, and by that I mean you may have to be patient for a few days and sometimes even for a couple of weeks. Critical illness in intensive care is often 2 steps forward and 1 step back, so please be patient. So let's move on to the third most frequently asked question. Is my critically ill loved one in pain while they are in an induced coma and are not waking up? This is one of the most frequently asked questions I get when working with families of critically ill patients in intensive care, either in practice or on the phone, via Skype, via email, and again in my clinical practice. As I explained in question number 2, painkillers or opiates such as morphine, fentanyl, oxycodone or remifentanil tend to be very, very potent drugs. Therefore, pain most of the time is not an issue with the right painkiller at the right time and the right dosage. pain can still be an issue during an induced coma, and it can't be ruled out, but again it should be manageable with the right dose at the right time and the right pain medication. If you are in doubt if your critically ill loved one is comfortable and pain-free, speak to the doctors and the nurses about your concerns, however also judge by your loved one's body language. Making your judgment by your critically ill loved one's body language, if they are in pain or not, is probably your best approach. For example, after major surgery, such as open heart surgery, as well as major trauma, pain obviously can be a significant issue. Therefore, depending on your critically ill loved one's tolerance towards pain, finding the right dose of morphine, fentanyl, oxycodone or remifentanil shouldn't be too much of an issue for the doctors and the nurses. Again, those painkillers tend to be very, very potent. If your critically ill loved one has been induced into a coma for mainly airway management issues, such as mechanical ventilation and the breathing tube, because they couldn't breathe, or if your critically ill loved one required the induced coma because they are hemodynamically or otherwise unstable, painkillers should be kept at a bare minimum. Without the issues of severe pain, such as after major surgery or after major trauma, pain medications should be minimized as much as possible for an induced coma, purely for mechanical ventilation with a breathing tube, as well as hemodynamic instability. Yes, mechanical ventilation and the breathing tube can be painful and uncomfortable, there is no doubt about that. But can you imagine if on top of the mechanical ventilation and the breathing tube, you also had major surgery and or major trauma? The pain thresholds are quite different in those different circumstances, and therefore the doses of morphine, fentanyl, oxycodone or remifentanil given should vary as well. Especially if the induced coma is prolonged. However, the risk is also in overdosing with either pain medication or the sedatives. On the one hand, you want to make sure that critically ill patients in an induced coma are comatose, so that they can rest and heal, as well as tolerate mechanical ventilation and the breathing tube. On the other hand, the coma shouldn't be too deep in order to get your critically ill loved one out of the induced coma when the time is right and appropriate. Also, have ongoing and uninterrupted vital organ function through stable hemodynamic body function, such as heart, liver and kidney function. If the coma is too deep, blood pressure tends to be lower, and therefore vital organs may not get sufficient blood and oxygen perfusion and supply. Furthermore, as I have pointed out before, in a prolonged induced coma, your critically ill loved one might get addicted to midazolam or worse, and or the painkillers such as morphine, fentanyl, oxycodone or remifentanil. Therefore, waking up after an induced coma may become more complicated and more difficult if withdrawal from the sedatives and the painkillers becomes an issue and needs to be managed. Any of the things that I mentioned before is usually thrown out of the window if your critically ill loved one has severe pain, has had major surgery and or major trauma, and another complicating factor is usually alcohol or drug abuse. Any of the above and or a combination of the above can dramatically increase the need for painkillers or opiates, and therefore can also make waking up from the induced coma more difficult down the line. As I have mentioned before, even if your critically ill loved one looks uncomfortable and in pain, most critically ill patients in intensive care don't remember anything about their stay in intensive care. Nevertheless, finding the right balance between being comfortable and pain-free and not being sedated too deeply so that waking up in a reasonable time frame can be achieved can be challenging, and it can be like a walk on a tightrope. By now you have a very good understanding why your critically ill loved one has been induced into a coma, and by now you also have a very good understanding why waking up may not be as straightforward as you would like it to be. As a side note, for some critically ill patients in intensive care, epidural might be appropriate for pain management. An epidural catheter is a medical route of administration in which a drug is injected in the epidural space of the spinal cord. Techniques include epidural analgesia, and analgesia stands for painkiller, and it involves injections of drugs through a catheter placed into the epidural space. The injection of painkillers, which is usually a mix of bupivacaine and morphine or fentanyl, the injection can result in loss of sensation, including the sensation of pain, by blocking the transmission signals through nerve fibers in or near the spinal cord. An epidural can be used after cardiac surgery, after lung transplants, abdominal surgery, and sometimes in trauma patients as well. If the epidural catheter is placed in the right spot, it can be very effective, and waking up can be a lot quicker. If the epidural catheter doesn't work, it can result in significant pain for a critically ill patient, and therefore going back to intravenous morphine, fentanyl, oxycodone or remifentanil is the most likely course of action. Let's move on to the fourth question. Can my critically ill loved one hear, see or feel me while they are in the induced coma? This is another question that I get asked very frequently when critically ill patients don't wake up as expected after an induced coma. It's also a question I get asked frequently when families have a loved one critically ill in an induced coma. Now, here are the things that you need to know and that are important when it comes to induced coma and being able to see, hear and feel. Most critically ill patients in intensive care who are or have been in an induced coma don't remember their stay in intensive care, and if they do remember their stay in ICU, it's usually fragmented, incomplete or foggy. This doesn't come as a surprise to me at all, given the potency and the effects of the drugs that are given in an induced coma. Whether it's midazolam, Versed, propofol or dipravan, morphine or fentanyl, they are very potent drugs that are being used not only for the induction of a coma in intensive care, they are also being used for anesthesia to do surgery. Therefore, the potency and the effects of the drugs are basically wiping out your loved one's memory, at least for a while. I would strongly argue that even though your critically ill loved one most likely won't remember much of their stay in intensive care, that you still talk to them as if they were a normal person. Nothing seems to be worse than dehumanizing a person just because they are critically ill in intensive care and in an induced coma. Therefore, as bad as the situation appears to be, your critically ill loved one still needs the human touch and the familiarity that comes from their immediate family and loved ones. I strongly believe that your critically ill loved one's subconscious mind will still register a familiar voice in an unfamiliar and strange environment. Therefore, I believe that treating your loved one like a human and as if they were conscious is the right approach, and it helps you as well by treating them like a normal person. I have seen way too many families in intensive care who are actually afraid of talking to or even touching their critically ill loved one while they are in the induced coma. It's not going to help you or your critically ill loved one. Give them the human touch, as you would normally do, even though you know now that most critically ill patients in intensive care are not remembering much of their stay in intensive care if they've been in the induced coma. Your loved one as well as you and your family have much to gain from your human touch and your compassion to be human. Let's move on to question number 5. Can my critically ill loved one be in an induced coma, try and wake up from the induced coma and then get off the ventilator? Again, this is the chicken or egg question. This is another one of those questions that I get all the time from families in intensive care, where their loved one is either in an induced coma or is trying to wake up after an induced coma. This really is a chicken or egg question. There is no induced coma without mechanical ventilation, and there is no mechanical ventilation without an induced coma. The question is, which one is first, the mechanical ventilation or the induced coma? The answer is that it all depends. Let me explain and illustrate with some real-world examples. Let's just say that your 78-year-old dad gets admitted to intensive care with pneumonia. At first, your dad is struggling to breathe and he's in need of some low-grade oxygen. Your dad had a chest x-ray to determine the location of the pneumonia and also the severity of the pneumonia. The chest x-ray shows some significant right lower lobe consolidation in the lungs, which is fluid in the air spaces of the lungs, which is the reason why your dad is struggling to breathe and why he needs oxygen. In order to manage the pneumonia and to get rid of the right lower lobe consolidation in the lungs, he will need intravenous antibiotics, and he will also need positive pressure into his lungs, as he's currently too sick and too weak to do breathing exercises that could help him fight the pneumonia. Therefore, the best option forward is to get your dad on a mechanical ventilator with a breathing tube in his throat. The mechanical ventilation and the breathing tube will give your dad positive pressure into the lungs that will help with opening up the consolidated parts of the lungs. It'll also give your dad time to rest and heal while he is asleep and in the induced coma. Now, as I explained before, mechanical ventilation and the breathing tube in the throat are extremely uncomfortable and very painful for somebody who is awake. Therefore, before your dad or any other patient in similar circumstances is commenced on mechanical ventilation with a breathing tube in their throat, they need a fair amount of sedatives like propofol, dipravan or midazolam or Versed, as well as morphine, fentanyl or remifentanil. One goes with the other. There is no mechanical ventilation without an induced coma, and there is no induced coma without mechanical ventilation. One wouldn't be safe without the other. By the time your dad gets put to sleep and into the induced coma, he's also getting the breathing tube and the mechanical ventilation simultaneously. It all goes hand in hand and is usually done within 10 to 20 minutes if all goes smoothly. Another example for the induction of a coma and hence mechanical ventilation and the breathing tube would be for a critically ill patient who just sustained major trauma and required emergency surgery. Let's just say your 23-year-old brother was riding on his motorbike and had an accident. He fractured some of his ribs and he sustained severe leg fractures. Thankfully, he has no head or brain injuries. He had to be rushed off to the operating theatre to get his legs fixed straight away, and even though he was awake and breathing in the ambulance and the emergency room, he got intubated. Again, intubation is the insertion of a breathing tube in the throat and commencement of mechanical ventilation, and he was induced into a coma for A, the mechanical ventilation, and B, the leg surgery. After your 23-year-old brother had leg surgery, he was admitted to intensive care because he wasn't ready to be woken up, and the intensive care team also decided to keep him ventilated for a few days because of his fractured ribs. Therefore, inducing a coma and commencing mechanical ventilation with a breathing tube is a process that's well aligned with the needs of a critically ill patient. In most circumstances, your critically ill loved one, when induced into a coma, will also get a paralyzing agent to chemically and temporarily introduce the blockage of the muscles. This helps while intubating. Again, intubation is the insertion of a breathing tube into the throat. And whilst your critically ill loved one is being intubated, the muscle relaxant makes it safer because it relaxes the muscles. A paralyzing agent such as rocuronium, vecuronium, cisatracurium, just to name a few, should be a temporary measure. However, in some instances where a critically ill patient can't be ventilated properly or where they can't be sedated properly, a paralyzing agent might be given for a couple of days to help keeping your loved one in the induced coma. Most critically ill patients will only need a paralyzing agent at the induction of the coma to smoothly intubate and ventilate a patient. Being paralyzed with a paralyzing agent and having the muscles completely relaxed for a couple of days should be avoided if possible, as it can have undesired side effects and it's a relatively risky endeavor, even in a high risk and controlled environment such as intensive care. If your loved one needs paralyzing agents for a couple of days or even longer to help with the induced coma and the mechanical ventilation, it tends to delay waking up after an induced coma even more. It's not only that your critically ill loved one is paralyzed whilst receiving the paralyzing agents, your loved one will also need more sedatives and painkillers during this period where they are paralyzed. Therefore, you and your family may want to find out if your critically ill loved one has been receiving paralyzing agents during the induced coma, to determine if a longer time period for waking up after the induced coma can be expected. The questions that I get all the time are: why is my critically ill loved one not waking up after the induced coma? And also, how long does it take to wake up after the induced coma? And those were the first two questions in this video. Funnily enough, I sometimes also get asked, how long will it take until my loved one gets off the ventilator? But I don't get asked this question as often as how long will it take to wake up after the induced coma. As I mentioned before, waking up after an induced coma is going hand in hand with your loved one breathing by themselves and getting rid of the breathing tube and the ventilator, which is also called extubation. Just like introducing your critically ill loved one into an induced coma is going hand in hand with intubation, waking up after an induced coma is going hand in hand with extubation. Again, that's getting rid of the breathing tube and the ventilator. One is just as important as the other. However, unlike during the induction of the coma, where mechanical ventilation and the breathing tube are introduced simultaneously, when coming out of the induced coma, waking up needs to come before the extubation or getting rid of the breathing tube and the ventilator. Once your loved one has woken up from the induced coma and is doing all the right things, such as following simple instructions like squeezing hands and wiggling feet and toes or poking out their tongue, they should also be breathing with minimal support from the ventilator. Usually, waking up after an induced coma, especially when it's longer than expected, is going through stages like opening eyes to command and then opening eyes spontaneously, as well as moving arms and legs to command and then moving them spontaneously. Another good sign is actually if your critically ill loved one is trying to remove the breathing tube by themselves, even though it should be done by the nurses and not by your loved one. It could cause damage if your loved one is taking the breathing tube out by themselves rather than having it removed by a professional. So this concludes part 1 of the 10 answers to the 10 most frequently asked questions when your loved one isn't waking up after an induced coma. So I'll see you in the next video. Take a break and I'll see you shortly. Thank you.